Welcome, everyone. Megan Parley, the project coordinator for the California Evidence-Based Clearinghouse for Child Welfare, or CEBC for short. I'd like to thank you all for joining us and welcome you to the webinar. Thank you for answering the poll question. This will be helpful information for our presenter. We've muted your phones due to the high number of participants attending. So if you're experiencing any technical difficulties or have any urgent questions, please use the Q&A pod that's located on the right side of the screen, and we will do our best to assist you. We will have a brief Q&A section halfway through and then at the end of the webinar. So please use that same Q&A pod to send us your questions. Lastly, you will receive a link shortly after the conclusion of this webinar to complete an easy survey so we can continue to improve our webinars and make them as useful and beneficial as possible in the future. Now, just a brief introduction of our presenter. Dr. Ben Saunders is a professor in the Department of Psychiatry and Behavior Sciences at the Medical University of South Carolina in Charleston. There he serves as the Associate Director of the National Crime Victims Research and Treatment Center and as the Director of the NCVC's Family and Child Program. His research, training, and clinical interests include the initial and long-term impact of violence and abuse on children and adolescents, the epidemiology of treatment of trauma, violence, and abuse, treatment approaches for abused children and their families, and effective methods for disseminating and implementing evidence-supported interventions in community service agencies. Currently, Dr. Saunders directs several projects concerned with implementing evidence-supported interventions in frontline community service organizations. In addition, he provides clinical supervision, consultation, training, and program consultation concerning mental health treatment of abused children and their families. Dr. Saunders also has served as a member of the CEBC's scientific panel since it was formed in 2004. And now I will pass it on to Ben.
Thank you, Megan. I appreciate that. And welcome to all that have joined the call. This is a little bit of a strange situation where we have one-way communication except for your ability to type out questions. Let me encourage you that if you have questions as we go along the way, feel free to do that. Today we're going to talk about something that actually is very, very good news in our field. When I first joined the field some years ago, we knew that abuse and adverse childhood events caused many, many difficult problems among kids, but we really did not have good evidence about what types of treatment might be helpful. And so since that time, there's been a lot of clinical research done, and we now are actually in a much better place in terms of interventions. And so today we're going to discuss some of those interventions that have been tested, found to be effective, and highlight some ones that you might want to look into if you're not already familiar with them. And of course, the California Evidence-Based Clearinghouse is the first place that you would want to start as you begin to look at that. Just to let you know that this is a little where this slide here is who is hosting this, and the fact that they disavow all knowledge of anything I'm going to say and at the Rady Children's Center. So that's that disclaimer. Would like to first just remind everybody what we mean when we say the term evidence-supported intervention. And of course, there are other terms that are often used for this particular concept. The most common is probably evidence-based treatment. We also hear about evidence-based practice or evidence-based practices, and the notion of an evidence-based intervention. Essentially, they all mean the same thing. They typically mean that the intervention has been tested through some sort of rigorous scientific study, and that it meets some defined threshold of research evidence for its efficacy. Now, different folks will define this in different ways. And one of the real pluses of the California Evidence-Based Clearinghouse for Child Welfare is that the definitions of the various rating categories are extraordinarily well defined. You can look at them and really understand what is meant by the various ratings. That is not always true in some places, and it certainly isn't true when we hear people talk rather casually about the notion of an evidence-based treatment or an evidence-supported intervention. So I strongly encourage people that when they hear people use that term, that they really read the fine print. What exactly do they mean? And when they say it has met a threshold of efficacy, of research for its efficacy, what is that threshold? Now, commonly, what that usually means is that the intervention has been tested at least twice utilizing a well-conducted randomized clinical trial methodology. There are at least 2 randomized controlled trials with some sort of positive follow-up. In other words, they went back and they found out that the treatment effect held up over a certain period of time. And of course, if an RCT was conducted by a non-developer, somebody that really did not have a stake in the development of the intervention, that also is a very positive thing. This particular slide here just lists some things that, if they are present, they increase our confidence in that particular intervention. And it basically boils down to the more research that has been done that has found positive results for this particular intervention, and that the effect sizes achieved were of clinical significance, things that we would care about clinically, the more of that we see, the more confidence we have that this particular intervention is in fact effective. We also like to see the intervention used with multiple populations. So oftentimes what happens is an intervention will be tested with a relatively narrow population. As the research grows, they will try it with other populations, and if we find positive results, that increases our confidence in that intervention as well. Now, if you want to find out more about evidence-supported interventions, the CEBC is a great place to go. And this is the rating scale that they typically use, and it runs from very well supported to a concerning treatment. So there will be some interventions that have multiple randomized clinical trials. They've been tested by using many different types of populations. Someone other than the developer of the intervention has conducted an RCT, and perhaps even there's been things like a meta-analysis interventions that have less support behind them, but they're still strong and still well supported. These might fall in the 2 or a 3 category. Then we might move into those interventions that perhaps there is no research demonstrating their efficacy, or just minimal types of things like pre-post tests with no control. And then we also have interventions that actually might be concerning, where the research has found that there are some side effects or some negative impact of a treatment, and these might be things that we want to avoid. Also in the CEBC, there's a fair number of interventions that simply cannot be rated yet because they have not been tested in any formal way. So I just want to let folks know what those criteria might be, and encourage you that when you hear the term evidence-based practice, evidence-supported intervention, whatever term is used, that you really read the fine print and find out exactly what folks are talking about, because not all of the definitions are consistent. I wanted to highlight on this slide that as good as the CEBC is, it is not the only place where you can find this sort of information. And so SAMHSA, the Substance Abuse and Mental Health Services Administration of the federal government, runs the National Registry of Evidence-Based Programs. You can go to that website and search it. It's much broader than child abuse, much broader than child welfare, and see what it lists for a variety of interventions. The same thing with the Child Welfare Information Gateway. And there are others that you can go to. Crime Solutions that is run by the U.S. Justice Department, the Blueprints Project, which is run by the University of Colorado. So there are these other areas that you can go to learn more about evidence-based interventions as well. Now, what we'd like to talk about today a little bit is just, I'm going to if you're in the child abuse or child welfare business, that these generally treat problems that are commonly experienced by victimized children and adolescents. Most have at least some evidence for their effectiveness. Some have a great deal of evidence and are actually frontline treatments that would be our first choice when we're working with some of these children. All have a manual, all have other kind of training and learning aids that you can obtain to learn more about the intervention. All have in-person expert training available. It might not be in your area, but it's available somewhere. All can be implemented and have been implemented in frontline community service agencies, and you can do that with an adequate level of fidelity. So these are interventions that are supported by research. You can probably learn them by going to training and books and manuals and this other sort of type of thing, and they're can be used and be effective in frontline service centers. The first I'd like to highlight, and this is a treatment that maybe you haven't thought about in terms of using with kids. It's a very well-known intervention with adults, and that is cognitive processing therapy. This was developed by Dr. Patty Resick and her group when she was at the University of Missouri, St. Louis. She's now at the National Center for PTSD in Boston. It's a very well-known treatment. It's a very specific treatment. It was designed for adult sexual assault victims. However, it's also used with older adolescent sexual assault victims. It turns out that the folks that were included in the randomized clinical trials done with CPT, participants were oftentimes 16, 17, 18, 19-year-olds, been found to be effective, multiple randomized clinical trials, but it has not been specifically tested with adolescents. And there is a book available. This is it that you can see on the slide. It is a fairly specific treatment. It is 12 sessions. It follows, in some ways, a reasonably standard cognitive processing therapy type of approach, psychoeducation, an impact statement. People learn the ABC model of thoughts, feelings, and behaviors. There's of kids with or adolescents with PTSD, challenging faulty thinking, challenging maladaptive cognitions, and there are very specific modules covering issues that are often of significance to sexual assault victims, and that's safety, trust, power, control, and self-esteem and intimacy. And one advantage of CPT is that it's a very specific protocol. It is one of these protocols where session 1 you do this, session 2 you do that, session 3 you do the next thing. There's homework involved and exercises for folks to do at home, and Yeah, the downside is there's not much flexibility to CPT. You're pretty much supposed to do it in a session-by-session way. I wanted to highlight also that there is a free training course in CPT that you can take. This was developed by our group here at MUSC, and in collaboration with the developers of CPT, Dr. Patty Resick and her colleagues. It is free. It's a multimedia online course. If you have taken some of our other courses like TFCBT Web, then it looks very similar to that course. You will get 9 hours of CE credit. Now, the one thing that I want to highlight is you'll notice on this slide that there's an American flag and some dog tags. That's because this teaches the version of CPT that is used with combat veterans. However, the CPT protocol that you use with sexual assault victims is very similar. The examples are a little different, obviously, but in terms of the techniques and the specific procedures, they're exactly the same. So you can take CPT Web and really get some good training in how to do it and actually utilize it with sexual assault victims. And this is a free course, so I wanted to highlight that. So that is CPT. I want to move on now to a second intervention. This is Cognitive Behavioral Intervention for Trauma in Schools. The acronym that is most often used is CEBC. And essentially, this is cognitive behavioral therapy for kids that have experienced trauma and have some type of post-traumatic stress symptoms, but it is typically delivered in school settings. This particular intervention is for kids as young as 8, kids as old as 15. That's who it's been tested with. It's designed to reduce symptoms of post-traumatic stress. It follows a cognitive behavioral therapy approach in that it's designed to build skills in order to help children manage the post-traumatic stress symptoms that they are experiencing. The couple of unique aspects of CEBC compared to some other cognitive behavioral therapy-based trauma treatments are, number one, it is designed to capitalize on building peer support. CEBC is typically delivered in a group setting at school. It can be either after school or during school hours, depending on how the school system works. But peers are involved in this. So this is an intervention in which the building of peer support and helping kids as a group learn these skills, you're capitalizing on the power of a group therapy approach. It uses the common CBT techniques, which you can take a look at if you go to the CEBC. It'll have those all laid out, but it's psychoeducation and relaxation skills, cognitive processing skills, those types of things. And another unique aspect is there is no parent or caregiver component to this. So this is strictly for kids. Typically, parents or caregivers are not involved in a CEBC program. My guess is that in different settings, there may be some places where they are involving parents or caregivers, but that was not the way CEBC was designed to be delivered. It's currently rated a 3, or a promising practice, promising research evidence in the CEBC, which means that we have one or two, I think there's actually 2 RCTs with CEBC, but what I think we're lacking is the follow-up data around. It is very well disseminated across the country. And you can, within the CEBC, you can learn how to get more training, but training in CBITS actually is offered reasonably frequently across the country, and if you can contact the developer, you will be able to learn where that might be. This is our third intervention, child family traumatic stress intervention. This is a very recently developed intervention. There's one randomized controlled trial demonstrating its efficacy. A reasonably large trial was done, I think, with a little over 100 children. It's for kids ages to 7 to 18. This is designed to be delivered relatively soon after the exposure to an acute traumatic event, or relatively soon after the disclosure by a child of being abused or sexually assaulted or something such as that. It's designed to be a brief, almost prevention type of intervention. It's not a treatment, really a long-term treatment for kids with PTSD symptoms. It's really for those kids soon after the delivery, doing 4 sessions where you're attempting to build caregiver support, facilitate caregiver and child communication around the particular intervention, reduce trauma symptoms as they occur soon after the disclosure or after exposure, and then essentially assess the need for longer-term treatment. And it turns out that many children with a relatively short, brief, but very targeted type of intervention such as this, that this can help prevent the development of more serious post-traumatic stress symptoms and perhaps reduce the need for longer-term treatment for these kids. Again, this is a very new treatment, a promising treatment, but one that I think you probably need to take a look at. Our next treatment is prolonged exposure for adolescents. This was developed by Dr. Edna Foa and her colleagues at the University of Pennsylvania. Many of you are probably familiar with prolonged exposure treatment as a frontline, extremely well-supported treatment for adults who have post-traumatic stress disorder. Originally developed for adult rape victims, has been used extensively and adopted by the Veterans Administration for treating combat veterans with PTSD. It's probably the most used intervention within the VA system. There is now an adolescent version of this. We have one randomized controlled trial with adolescents, a relatively small sample. However, we have multiple randomized controlled trials of prolonged exposure with adults. The nature of the treatment is exactly as it sounds. There's a psychoeducation component, but the primary component is, in fact, in vivo and imaginal exposure. And there's some use of breathing as a relaxation type of coping mechanism, but the primary component, active component of this intervention is the exposure to the component. There is a manual and a book which you can see here, which you can purchase, and probably the level of availability of treatment for this particular intervention is not quite as high as some of the others, but you can contact Dr. Foa's center and learn more about training that might be available. The next treatment I want to highlight is alternatives for families, a cognitive behavioral therapy, or also known as AFCBT. AFCBT is actually a relatively unique treatment within the field. This is a treatment that is designed for both parents and school-age kids in which there has been physical abuse. There are components for the parent designed to reduce the likelihood that they will physically abuse their child again. So the treatment is for the physically abusive parent. It is also has components for the child that perhaps may be experiencing traumatic stress symptoms or other symptoms, fear, anxiety, or depression, or behavior problems as a result of their physical abuse. This is a protocol that combines both of these purposes, reducing the likelihood of future abusive behavior by the parent, as well as reducing the mental health consequences to the child victim, all in one protocol. This is what makes AFCBT a unique and extremely important intervention within our field. You can see on anger management, there's a variety of different components here, and to see all of those, I would recommend that you look this up at the CEBC, and those will be listed. It is a combination of individual sessions and conjoint sessions between the abusive parent and the child victim. It's a very unique, very important treatment because it's one of the few treatments we have that directly targets physically abusive behavior by a parent and a child. Currently, it's rated a 3. I believe we have one RCT demonstrating the effectiveness of this intervention, and so it has promising research evidence. There is another RCT that's ongoing right now, and Dr. David Kolko and his colleagues who developed this intervention are currently conducting several implementation studies as well of utilizing AFCBT within frontline community treatments. This is, again, just a list of this slide is a list of, as you can see, the many components. And I will say one thing, AFCBT has a lot of moving parts. It's somewhat of a challenge to learn and somewhat of a challenge to do, because you are trying to do, number one, treat a very difficult problem of physical abuse, and as well as the mental health consequences of that to the child. Has a lot of components, but a very important treatment that my guess is we'll be hearing more about in the future. I apologize for going kind of quickly, but I'm making note of our time, and we have some questions that I need to answer. So again, you can go to the CEBC and learn more about each of these treatments. Child-parent psychotherapy, our next treatment we want to cover here. This is also a somewhat unique treatment in that it is for very young children. As you can see, it is for kids 5 and younger, all the way to infancy, really. The younger the child, obviously, the more the treatment is focused on the parent. The older the child, the more the child himself, him or herself is involved in the treatment. This was developed primarily for children that experience serious trauma as a result of domestic violence in the home. This is a treatment that is unique in that it is designed to be delivered in the home. So the parent and the child receive the treatment in the home and are engage with the therapist. This is not a treatment where the folks come to the therapist in their office. This is designed to make it ecologically valid. In other words, they are trying to deliver the treatment when exactly where it happened, and therefore tailor the treatment to the setting in which the domestic violence occurred. It's also been used with other forms of child trauma, but I think there are 3 and get that. Interestingly, this treatment is theoretically eclectic. Unlike the other treatments that we've taken a look at, this has psychodynamic and attachment theory basis. It certainly makes use of cognitive behavioral therapy concepts and techniques, but it also makes very strong use of psychodynamic and attachment theory types of approaches as well. It's a very tailored type of intervention. Unlike cognitive processing therapy, where session 1 you do this, session 2 you do this, this is much more flexible, extraordinarily flexible, as a matter of fact, based upon the clinical demands of the moment and responsive to what is going on with the family. It's relatively long. Can take upwards of a year to deliver. I think the average length of delivery is about 26 weeks, if I remember correctly. So it is a relatively long treatment, but it's one of the few that we have that's been found effective with these very young children. These are the therapeutic objectives of CPT that you can see, and you can sort of see the psychodynamic approach here that is there. Relationship-based and really focusing on the parent-child relationship with these very young children. Again, with the very, very young children, more of a focus on the parent. The older children, more of a focus of the interaction between the child and the parent. Our next treatment we want to take a look at and be aware of is parent-child interaction therapy, and my guess is most of you are familiar with PCIT. I've got a lot of slides on it, but I'm not going to cover all of the material here. PCIT was originally developed for preschool children with a significant emotional behavioral problems, particular kids with oppositional defiant disorder. It's more recently been adapted for parents that have been physically abusive to their kids. Specific goal is to change parent-child interaction and increase positive interactions between parents and kids to disrupt those escalating, coercive, kind of negative cycles that parents and kids get involved with. And for our purposes, also to reduce physically abusive behavior on the part of the parent towards the child. It's currently rated a 1, very well supported. PCIT itself probably has over 40 randomized controlled trials. However, I believe there's only 2 at this point that have been conducted with physically abusive parents. But still, it's very effective in engaging parents in more helpful behavior. Structure of PCIT, assessment sessions, then there are treatment sessions, and then live skill coaching. And the cornerstone of PCIT is really the live coaching, where a parent is interacting with a child and receiving live coaching in the parenting skills from a therapist. The common way this is done by utilizing a bug in the ear, a receiver that is placed within the ear of the parent. The therapist is actually outside the room observing behind a one-way mirror. When the parent is involved in the interaction, the therapist is coaching the parent in how to respond to the child. So it's a very very hands-on, very direct type of to the child. The goal is to get the parent to use what are called the pride skills of parenting: praise, reflect, imitation, description, and enthusiasm, and also learn to follow the child, which is a skill that many parents often don't have. Second component is parent-directed interaction, where the parent is learning limit setting, consistency, problem solving, reasoning with the child, all the types of behavioral parenting skills that many of us would be familiar with. Training can be obtained from the PCIT developers as well as approved trainers that are around the country. and you can learn those contact informations from the CEBC. I did want to highlight the work done by Mark Chaffin in Oklahoma of utilizing PCIT with physically abusive parents. These were parents that had been physically abusive with multiple CPS referrals. As a result, the kids were between the ages of 4 and 12, so this is an older set of children than the usual target population of PCIT. Focus on parental behavior as opposed to the interaction, and it really becomes a delivery system for getting physically abusive parents to use good parenting skills behaviorally and behavioral management skills. And in this particular study, the re-referral rate by the parents that had received PCIT is dramatically lower than those that had received a treatment as usual type of intervention. So we do have interesting research demonstrating the effectiveness of PCIT with physically abusive parents. Also want to highlight EMDR, eye movement desensitization and reprocessing therapy. This is a therapy that is conducted in 8 phases, and essentially the primary active ingredient is repeated exposure to the emotionally disturbing material, the traumatic event, the memories of the traumatic events that the client is having difficulty with what the EMDR folks call bilateral stimulation. This typically began as having the client move their eyes from side to side, and the theory was that as they did that this increased the effectiveness of the exposure and reprocessing portions of the treatment. There was some controversy around that. There were some studies that have demonstrated that really the movement of the eyes does not seem to add significantly to the effectiveness of the treatment. There have been other studies that have looked at auditory tones that alternated between the right and the left ear, tapping, or other types of tactile stimulation, and have found equal types of effects. So there are questions as to the necessity of this external stimulus portion of EMDR. And some have argued that if the eye movement portion of this is really not necessary, then what we are really left with is desensitization and reprocessing, which is essentially cognitive behavioral therapy. The EMDR folks, of course, argue against that and maintain that this bilateral stimulation is necessary. So you can take a look at that research, and you can take a look at this description on your own and draw your own conclusions. At any rate, EMDR is rated a 1, a very well-supported research, multiple RCTs demonstrating its effectiveness in this way. Our last intervention here is trauma-focused cognitive behavioral therapy. And this is probably our most well-supported intervention for kids that have experienced traumatic stress, and it has very strong empirical support. We have over 10 randomized controlled trials, specifically with traumatized children. It's ranked a 1 in the CEBC, and also very highly ranked in these other interventions that we can look at. Target criteria for TFCBT, they're listed here in this slide. These are basically for younger kids and kids up to age 17. Kids obviously need to have a trauma history for this to be effective. They also need to have significant symptoms of PTSD. They might have other trauma-related problems as well, and parent and caregivers' involvement is highly desirable in this particular intervention. Where TFCBT would not be indicated is when kids don't have a trauma history, don't have mental health symptoms related to traumatic event. There are also children that may have such severe cognitive disabilities that they really cannot benefit from a cognitive therapy, and in that case, TFCB would not be indicated. Severe disruptive behavior that just doesn't allow them to engage in treatment, that it may not be able to be appropriate for those particular children. I do want to comment that if you have questions about the interventions that we're covering, you obviously can get much more information about all of these from the California Evidence-Based Clearinghouse, and you can simply go to the clearinghouse and search for these interventions, and you can get a very detailed report about all of these interventions, when they're used for, their treatment components, where training can be found. All of this can be found on the CEBC. With TFCBT, I want to highlight the treatment components. It's trauma-focused CBT. It follows a component approach, which you can see here spells out the acronym PRACTICE, psychoeducation and parenting skills, relaxation, affective modulation, the other components here. Probably the seminal piece of TFCBT is the fact that the child and the therapist and the parent are engaged in a trauma narrative, constructing a trauma narrative piece. This is a gradual exposure technique that is used with the child to develop a written narrative typically. Other media can be used, but oftentimes a written narrative of their trauma and their trauma symptoms. This is then shared with the parent as need be. Some things about TFCBT. This is not a session 1, session 2, session 3, you do this type of thing. However, it's typically conducted between 12 and 24 sessions. Treatment frequency is usually once a week. And for the most part, you spend about a third of your time on what are called developing the PRAC skills. That would be the psychoed, relaxation, affective modulation, and cognitive coping. You spend about a third of the time developing the trauma narrative, and then you spend about a third of the time working on enhancing future safety, conjoint child-parent sessions, those types of things. So it's a phase type of treatment. It does have a beginning, a middle, and an end, but it doesn't necessarily have session 1, session 2, session 3. Training is available for TFCBT. This is an online training course that we developed for TFCBT called TFCBT Web, free of charge. 10 hours of continuing education credit is offered. It's a totally free course, and you can go and learn all of the components of TFCBT. There's also a follow-up course to TFCBT Web called CTG Web. This is for applying TFCBT to cases of child traumatic grief. So cases where a child has lost a close friend or family member to some sort of traumatic death. And this is how to use TFCBT in those particular cases. Again, free of charge, 6 hours of CE. We also have an automated which you can see here. You go to TFCBT Consult, and if you'll look down here where it says click here for a question. Let's see if I can pull I can't pull the arrow over. It's not working. You can actually go into this and enter some keywords or enter a question, and a set of answer pages will pop up that have been developed with the developers of TFCBT. And you can actually get an answer to all the most common questions that you might have about implementing TFCBT. So you can only use TFCBT Consult after you have completed TFCBT Web. And you simply use the same login and that type of thing that you use for TFCBT Web to use TFCBT Consult. So you can actually learn TFCBT and get automated clinical consultation in that way. There's also a regular program of TFCBT training that occurs nationwide, and you can contact the developers for those where that might be obtained. So I'm going to stop here. Actually, I'm going to stop here quickly and answer a couple of questions as best we can about the interventions that have been brought up. So one question here is, does taking the CPT course certify you to use this form of treatment? The answer is no. There is no certification for utilizing CPT. And I encourage folks that when they take the online course, it is what it is. You will see demonstrations, you will learn the components, but it's very akin to reading a book, other than you get to see the multimedia part. Taking the CPT course online probably will prepare you to at least begin to utilize CPT. It's obviously better if you can obtain some type of training and supervision. Regarding CBITS, how are referrals made? Parents, schools, staff? I would assume that referrals are made by all of those folks to CBITS implementation. Again, it's typically done for kids in schools, so referrals come from all of those various places. One question is, can you use AFCBT with young parents? With young parents ages 15 to 24? That's a great question, and I, quite frankly, don't know the answer to that question. I don't see why not. The treatment would still be applicable to young parents, but I would suggest that you could contact the developers and ask that particular question. But off the top of my head, I can't see why it wouldn't be used with young parents. Then last question, can AFCBT be used when the youth is in fact being physically abusive toward parent or siblings? Again, I don't know the answer to that question. It was designed for a physically abusive parent, so the idea of the youth being physically abusive to the parent, I guess, would not fall into the category of utilizing AFCBT. So let's move on and talk about, quickly, we've got about 10 minutes left here. We see so many interventions here. How do we go about making the decision about which one to use, or perhaps the 2 or 3 that I might want to use? I'd like to highlight this particular outline here, which is an outline that our group has developed called evidence-based treatment planning. And it basically is an approach for, an organized approach for developing what we term an evidence-based treatment plan. And that's utilizing systematic assessment to gather information about the family and about the child, and not only by the therapist, but utilizing other assessments that have been done by other people in the community. So one thing that I think that we all do when we're working in child abuse cases is everybody's doing assessments, but oftentimes that information is not shared with one another. And sometimes that's for confidentiality reasons, sometimes it's of getting releases and doing other things to deal with a confidentiality issue, so that different professionals that are doing assessments, whether they be forensic interviews, clinical assessments, medical assessments, CPS assessments, that folks that have information about the family can actually share that information with one another to broaden the scope of the intervention of the information that you have. This information is then integrated into a case formulation where we can utilize that. Here we go. There's my arrow. Is integrated, where we can integrate that information into a common case formulation. Out of that would grow a matrix of family strengths, needs, and problems that we have identified through the assessment process. Out of that would grow a set of measurable treatment intervention goals. And when we get to our measurable goals, that's when we begin to want to think about, okay, how can we match the goals with the interventions that we would use? So the cornerstone, of course, is assessment, and then we move to matching our goals and our goals with what treatments are available. We identify barriers that would prohibit the family from engaging in treatment. And then, of course, at the end of the day, we would monitor the impact of treatment. Just mention that the cornerstone is assessment. These are places from a community perspective where we might obtain information from multiple sources. In most child abuse cases, there's going to be multiple gatherers of information. We're probably going to use multiple methods to get that information. And then these are just some common targets that and strengths, needs, and problems, develop our behaviorally specific goals, trying to determine whether they can be measured, what metric we're going to use to measure them, how that goal is going to be achieved, and how will we know when we achieve success. Then comes our matching problem. And this is probably the one thing that people highlight about when we've identified all of those goals, those problems that families have, how do we go about matching the treatment to them? The first step is doing what many of you probably have already done, which is absolutely knowing what are the treatment targets and the appropriate populations for available evidence-supported interventions. And we just identified several of those evidence-supported interventions, talked about the treatment targets, talked about the populations. The good news is you can actually go to the CEBC and learn what those are for the interventions of interest. And you can actually then match the treatments to the specific problems that the intervention goals have revealed, taking into account the developmental age of the child, cultural issues, and other types of things that might be important. Now, one thing when we do this is that these kids have multiple problems. So what do? Do we need multiple interventions? We oftentimes have low-resource families, and they simply can't do complicated interventions or multiple interventions because they don't have the resources to be able to do that. And, of course, we have our difficult-to-engage families, poor participation, and poor treatment. One thing that I think it's important to know is that know the breadth of treatment for the ESIs that you're looking at. So though many treatments have been developed with one or two treatment targets, the research often reveals that there are what might be thought of as serendipitous impact of these treatments. In other words, we find that not only do PTSD symptoms go down, but guess what? The kid's behavior gets better, their academic performance gets better, they begin to develop better peer relationships. All of these things happen as a result of reductions in post-traumatic stress symptoms. So we don't necessarily need additional interventions for those secondary targets because the interventions that we're working with may have a fairly broad impact on the child and on the family. My probably better than having a fairly complicated treatment plan. And so picking out the one, perhaps two at most, interventions that are going to have the broadest impact on the problems and treatment goals that you have with a particular family is probably better than multiple interventions. So we know that the families, we need to understand their time, the effort, the resources that are going to be required for any treatment plan that we develop, and we need to know what is going to engage and motivate that family. That's going to impact on which intervention we pick. We actually want to understand and avoid this notion of intervention overload. We don't want to have so many interventions in a treatment plan that we actually reduce the impact of each individual intervention. And we do have data that suggests that every time we add an intervention to a treatment plan, every time we begin to increase the number of interventions in a treatment plan, we actually will reduce the impact of each individual intervention. What we want to think about is pick that broad band intervention that's going to have the best impact. We perhaps want to stage interventions over time. And then what I tell folks all the time is prepare to be surprised by the impact of doing one good thing. Doing one good intervention, a lot of times what you'll find is that those other problems will begin to dissipate by doing the one good thing. This particular slide is just about barriers. I want to, it's self-explanatory. I'm not going to cover that. This for this, and basically it boils it down to looking at internalizing symptoms versus externalizing. I'm actually not going to have time to comment on the notion of protocols versus component of parts, because I do want to say one thing about some comments that people have made here about some of the treatments. In terms of finding providers, I think the CEBC can be very helpful because it has the components, it has the description, it oftentimes has what is needed to be trained in the intervention. You can take a look at that and simply ask therapists, have they received training, do they use this treatment, and ask them about specific components of the treatment. If they're unable to tell you what the components adult sexual assault, and I think Megan has commented on that, the trauma treatment for adults is being loaded into the CEBC. So we are concerned with our parents in the child welfare system that might have trauma problems, trauma-related issues. There are good treatments and loaded into the CEBC, and it looks like that they will be that will begin to roll out in June. So I don't know if there are other questions that folks have, but it looks like that we are right at 2 o'clock, and I am going to, in the interest of respecting everybody's time, we will stop there. I'd like to thank everyone. I realize this is a boatload of information in a very short time. Again, encourage you to go to the CEBC website, learn more about these interventions and how they can be applied to the children that you work with. Thank you for all of you that participated, and as always,